Hi guys, welcome to week 4. This week we'll be talking a lot about vascular medications that are used to reduce hypertension, get rid of excess water, which we've already talked a little bit about, as well as cholesterol medications, and I forget what chapter 27 is, but we'll get to that point. Oh, I'm sorry, anticoagulants and antiplatelets. We're going to start off talking about diuretics, which a whole chapter is devoted to this in and of itself. And we've already talked a lot about diuretics with CHF and a couple of the other heart chapters that we talked about. So, chapter 25, diuretics are primarily used in the management of anuria, which is lack of making urine, hypertension, and edema. These are conditions in which the kidneys have stopped making urine and there's an accumulation of tissue or fluid in the tissues, and we talked about how that was called edema. There are 6 classes of diuretics, and you can follow right along in your slides. Osmotic agents, carbonic anhydrase inhibitors, thiazide and thiazide-like compounds, organic acids or loop diuretics, and potassium-sparing diuretics and ADH antagonists. Each of these classes of diuretics produces diuresis, which is the process of making more urine, by inhibiting water and or sodium ion reabsorption into the kidneys. Because these drugs inhibit water reabsorption at different sites along the nephrons, the intensity varies with each of the class of drugs. In general, the intensity of diuresis is dependent on the extent to which sodium ions are excreted into the urine. So, the kidneys are responsible for urine production. They have units within the kidneys known as nephrons, and the nephron is composed of several segments. So those segments are called the glomerulus, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. Urine is produced in the nephrons through the processes of filtration, reabsorption, and secretion. Vitamins, amino acids, and electrolytes pass into the glomerular filtrate, which ultimately becomes urine, but large molecules don't, like red blood cells, plasma proteins, etc. The remaining segments after the glomerulus are involved in reabsorption and secretion. So we're done with filtration, we've moved on to reabsorption and secretion. The proximal tubule, loop of Henle, and distal tubule contain specialized transport systems that pull ions out of the tubule lumen and transport them back into the blood, which is called reabsorption. One of the most important tubular reabsorption mechanisms is the transport of sodium ions into the circulation. Urine formation is essential for normal body function because it enables the body to reabsorb necessary nutrients, water, and electrolytes, and in addition, waste products are eliminated from the body through the urine. These processes take place again in the nephrons. We talked about the different segments of those. That slide has a little picture of the different parts of the nephrons. So if you become familiar with that, once we start talking about the diuretics and their mechanism of action, you can kind of picture where that might take place. Sodium ions are extremely important. We are on slide 8. Sodium ions are extremely important because they are the principal cations in the extracellular fluid. So where sodium ions go, generally water follows through an osmotic gradient, which is why we're so focused on sodium ions within the kidneys themselves. The major secretory functions of the nephrons involve the tubular secretion of hydrogen ions, potassium ions, weak acid, and weak bases. However, the tubular secretion of hydrogen ions also plays a role in the acid-base balance in the blood, as well as the urine. Urine is almost always acidic, whereas the blood is a little more alkaline, just a little bit above 7, but pretty neutral. Bicarbonate is also involved in this process of reabsorption and secretion, and that buffers the blood and keeps it right about at that neutral level. Any condition that impairs the renal production of hydrogen and bicarbonate ions alters the acid-base balance of the body, which is where we start getting into trouble with alkalosis or acidosis. So, moving on to slide 9. Renal function may be altered by renal disease or cardiovascular dysfunction. Usually, infection or inflammation in the renal tissues reduces renal function. Reduced renal function occurs in diseases like glomerulonephritis and pyelonephritis. We talked about how cardiac problems such as congestive heart failure or hypertension or shock decreases the amount of blood that gets to the kidneys and therefore can cause the kidneys to fail. Whether the renal tissue is damaged or blood flow is reduced, the ultimate result is decreased urine flow, decreased urine volume, or no urine production at all. As a result, the blood isn't adequately filtered and toxic products accumulate. That accumulation can lead to blood toxicity, swelling, and edema, and hypertension. Moving on to slide 10. I think, sorry, skipping ahead of myself here. So, these drugs are used to stimulate urine flow in the treatment of anuria, oliguria, before irreversible anuria and oliguria before irreversible renal damage occurs. So all of these diuretics are used for that purpose. Mannitol may be indicated for acute renal failure or in cardiovascular surgeries in which renal function is severely compromised. Increased urine flow is also valuable in the treatment of drug toxicity overdose, getting those drugs out of the body when we've overdosed a patient or when they've overdosed on something themselves. Osmotic diuretics are compounds that can be filtered by the glomerulus but not reabsorbed back into the renal tubules because they're pretty big compounds. Once inside the circulations, the drugs act osmotically, causing water to follow them. So because they can't cross back into the blood, water also does not cross. It stays with the osmotic diuretic, mannitol being the most popular one used. So although water reabsorption is inhibited, there is no major alteration of sodium reabsorption. Therefore, the diuresis is pretty mild. Again, we talked about the more sodium we get rid of, the heavier the diuresis. And there's no alteration in electrolyte or acid-base balance. Most often, the side effects from these medications include nausea, dizziness, headache, and chills. It's usually almost always given in a hospital setting. You don't see mannitol ever used in an outpatient setting. Mannitol is contraindicated for the treatment of chronic edema due to cardiovascular insufficiency, pulmonary edema, or active intracranial bleeding. Carbonic anhydrase inhibitors. Moving on to slide 11. Carbonic anhydrase inhibitors increase sodium and water excretion by inhibiting carbonic anhydrase. Since the hydrogen ion exchange is blocked, the distal convoluted tubules attempt to reabsorb sodium ions by increasing the potassium ion exchange. The increased secretion of potassium ions causes an increased loss of potassium in the urine. This can lead to hypokalemia. We've talked about how important that is. Since carbonic anhydrase is inhibited, little or no bicarbonate is produced to buffer the blood. Again, the problem on that end would mean the blood would become more acidic. The available hydrogen ions get into the bloodstream accompanied by chlorine, and that means hydrogen and chlorine are going to cause the blood to become more acidic, producing metabolic acidosis without that sodium bicarbonate there to buffer it. Acetazolamide is a carbonic anhydrase inhibitor that is a diuretic, and it increases, again, the same mechanism of action. That would be one example of that class. So, usually these medications are used in the treatment of congestive heart failure or drug-induced edema. They also help with glaucoma. They're available as eye drops in addition to oral or IV medications. We talked about acetazolamide. Another medication in this class is methazolamide. Usually they're used, if they're going to be used for CHF, they are used in combination with other medications. They're not used individually because they reduce, they're not used individually because they're not strong enough to really create a huge effect. The most common adverse effects produced by this group include drowsiness, anorexia, gastrointestinal distress, headache, depression, allergic reaction or rashes, and acidosis. Again, we talked about hypokalemia as well as hyperuricemia, which is the buildup of uric acid. So somebody who has gout might not want to use this medication. And also, of course, somebody who has acidosis as an existing condition already. Slide 13 gives you an example. It's a chart of carbonic anhydrase inhibitors. You take a look at that and become familiar with some of the names. Moving on to thiazides and thiazide-like diuretics. We've talked a lot about these already. Our hydrochlorothiazide, our chlorothiazide, our metolazone. These drugs are the largest class of diuretics. They're widely used in the treatment of edema with hypertension and can alleviate edema due to any cause. So we talked about using them in congestive heart failure, renal disease, hypertension, because they help get rid of that plasma volume, and they also relax smooth, vascular smooth muscle. So oftentimes they'll be used in combination with other diuretics to really produce a stronger effect. These are mild to moderate diuresing medications. These medications can cause hypokalemia. I think we discussed that before. They do not spare potassium. Potassium is excreted into the tubules and pushed out with the urine. So let's see. They also because they rapidly remove water and sodium from the body, this can cause orthostatic hypotension, which is a sudden drop in blood pressure when you go from a lying down or seated position to a standing position. In addition, it can cause hyperglycemia due to decreased glucose utilization. So patients who have diabetes will want to keep an eye on their sugars if they're using this medication. Sometimes, anytime we're getting rid of a lot of excess water, we're also getting rid of some electrolytes. Cramping can be pretty common with these medications, muscle cramps. So we always try to encourage patients to maintain their electrolyte balance, whether they're getting it from fruits or electrolyte drinks. Organic acid diuretics, and I've talked before, mostly these are called loop diuretics because they work on the loop of Henle. The organic acid diuretics, which have a greater diuretic action than the thiazides, are often used to relieve edema in patients who have become resistant to thiazide diuretics. They're generally useful in severe peripheral edema as well as pulmonary edema where greater diuretic activity is needed. And again, we talked about how they work in the loop of Henle, which is why they're so commonly called loop diuretics. It does cause a large loss of sodium, chloride, and water. These drugs are highly bound to plasma proteins, so anytime you have other drugs, they're open to a few more drug interactions than drugs that are not bound to plasma proteins. Moving on to slide 18. We'll talk about the side effects: nauseousness, hypotension, hypokalemia, hyperuricemia, again buildup of uric acid, which can aggravate gout, cause gout flare-ups, and hyperglycemia as well. In addition, these medications can cause ototoxicity, which is deafness, and that can be permanent, so we always want to not use them when we're using other medications that could also cause ototoxicity, such as aminoglycoside antibiotics. So moving on to potassium-sparing diuretics. This is our spironolactone, aldactone, triamterene. These inhibit potassium secretion in the distal convoluted tubule. They're useful in the management of edema. Oftentimes they're combined with loop or thiazide diuretics to balance out that potassium loss. Keep an eye on time here. Again, amiloride, spironolactone, triamterene are all potassium-sparing diuretics. So, let's see, what else can I tell you about these? This is mild diuresis. It's not going to be super heavy, and it doesn't have a whole lot of electrolyte changes or acid-base disturbances, so they're a little less worrisome when it comes to those side effects. Speaking of side effects, nauseousness, diarrhea, hyperkalemia, and gynecomastia, which is an increase in breast tissue, which can especially happen in males. It's very noticeable in males. Slide 20 gives you examples of potassium-sparing diuretics. We're going to pause here and go on to another video to cover the last 5 slides.